So, dear all, it's always a pleasure to welcome you all and to have you as a panelist in our webinar. And there is a lot of attendees who are waiting for that talk. We're glad that they are here, that you are here sharing with us. And we would like to thank all of our sponsor and our associates with our team. Our first talk will be with Dr. Maria, and she's from Greek, with the wisdom to share with us her talk. Please, Dr. Maria.
Thank you. I think you have to stop sharing now because I cannot share my screen. Okay,
I did it.
Thank you. So I would really like to thank Dr. Alqahtani for the kind invitation. I'm really glad to be in this panel meeting, So I am a private practitioner in Athens, Greece. I am specialized in medical retina, and I'm not sure I have much to offer, as thankfully Greece has not been very badly involved in this situation. So thankfully we have not been badly hit, and we are considered to be in a fairly safe situation at this moment. Our first case from a woman that traveled from Italy was on the 26th of February, and the first death on the 12th of March. The schools closed on the 11th of March, and the total lockdown was on the 23rd. So we are talking about a fairly early lockdown. So this is the Greek timeline till yesterday. Our first case and our first death, schools closure, and total lockdown. And so far, we have had 2,200 confirmed cases. The tests are being done mainly to patients that arrive in hospitals with highly suspicious COVID symptoms or that are hospitalized. Up till yesterday, we had 105 deaths only. So we are standing quite well due to the very early lockdown that we had. Obviously, there is an issue as to what is going to happen once the measures are going to be lifted. So the measures that were taken, the social distancing very early on was imperative. All shops were closed apart from supermarkets and pharmacies, and the confinement was very strict with allowed outings for specific reasons, and we have to actually send messages to text, or we have to have our forms completed when we go around to see someone that is in need, or to go to the pharmacy, or to go to work. So all this, the idea was to allow time to the health system to build extra capacity, which has been done. So the ICU beds were increased, and the total bed capacity was increased as well in the meantime. So the measures that were taken for the healthcare outside the ones that were taking care of the COVID patients. First of all, they managed to set up an electronic prescription without visit. That is of vital importance because we had a lot of visits every 3 to 6 months for patients that wanted repeat prescriptions. So they sorted that out. And the medical councils and the Ministry of Health advised against all routine or elective surgical cases, like in most countries. With regards to private offices, they were advised to stay open in order to reduce hospital burden. Telemedicine where possible, and that was strongly encouraged by the councils as well. Personal protective equipment was sent to private practices, obviously to hospitals as well, and that was taken care of with the medical councils in many cases. The problems that arose in my country were of a different nature. So because of the very early lockdown and the very strict measures, there were lots of, quite a few public hospital managers that expected all ophthalmic surgical cases to be postponed. Very few colleagues, to my knowledge, were reluctant to proceed with operations, but we still have a lot of patients that deny procedures, and procedures that were considered to be important to be taken care of. So the aim from the very start was to make sure that all essential services in ophthalmology will be provided. And an essential service is defined as a medical service that, if not given, will result in loss of life, function of limb or organ, or in our case, of visual loss. So the societies issued advice based on European, Canadian, American guidelines. And as you may know, what we talked about in clinics was that the regular follow-up appointments had to be postponed. The phone communication is strongly encouraged. The patients, when seen in the clinics, have to be seen with wide time slots to encourage the social distancing and make sure that the waiting rooms will not be crowded. The ophthalmologist has to wear protective equipment, only one patient in the examination room, and we have to discourage the chit chat or the talk not necessary, especially when the patient is sitting in the slit lamp or in the OCT. We all got our protective shields, even for the lasers and the OCT machines. And as far as I know, we are using surgical masks and gloves, but so far no goggles, no protective face wear or goggles have been used. With regards to surgery, it was very important to define the urgent and semi-urgent cases to the public health services, to the managers, even to the Ministry of Health. We have sent a lot of letters. So the retinal detachment macula on cases have to be done on time. The macula off in one eye patients have to be done. Obviously, the traps that, if not done, would compromise visual acuity. All the post-cataract complications from the pre-COVID era, traumas, wet AMD, and cases like uveitis or giant cell arteritis are considered to be urgent as well. There was quite some pressure to the Greek national health system to facilitate prescription of injections, causing in Greece there is an issue of how there is a lot of bureaucracy in order to get the injections, the Eylea, the Lucentis. So there has been some pressure in order to make that a bit easier with less paperwork, and we managed that. And there has been a suggestion of one-stop clinics for injections. That means that they will have their examination, their visual acuity taken if necessary, and then they will have the injection at the same time. That was not something that was done routinely in Greece. And obviously the visual acuity and OCT, as per guidelines, only if it's absolutely necessary. So at this stage, we are doing well. The guidelines, the feeling is that they're generally followed. Emergencies are all done. The more semi-urgent routine cases are treated on physician's discretion and mainly in private hospitals, as far as I know. The anti-VEGF injections are given as per guidelines, and all diabetic screening has been advised to be postponed. So there's a big issue of coming back to our routine on the phase 2 of this situation. There has been and there will be a strong financial stress on practices. And I believe there is a fine line between postponing surgery and safeguarding general health. And this is what we are called to resolve. Our elderly population in Greece is going to be asked to confine for much longer. And the social distancing is going to take, I don't know, until the vaccine is there. We have to make sure that rules and guidance will be properly followed by all health carers. There is a new era, a lot to learn. We have to train our patients on new behaviors and habits. We have to encourage social distancing. We have to make sure that they keep their appointment slots and they are not delayed. We have to reorganize our clinics. And as doctors, we have to be resilient and effective, not compromising our health. Very important, as I'm sure we're going to hear within the next few talks, the difficulty that the doctors face, and also make sure that our patients' well-being is kept. So it is a narrow passage, but hopefully we'll get to the other side of it with safety and wiser. Thank you for your attention.
It is on mute. Abdullah, yours is on mute.
Yes.
Alqahtani, we cannot hear you.
Yours yes.
I have a question for you, Dr. Maria.
Yeah.
How do you find the availability of the mask and the personal protective equipment and all that stuff? Is it really a matter for you? Do you think it's a crisis, and the shortage of that would affect the practice daily?
Okay, so what we have done so far, I have asked the medical council to send me masks, and these are being delayed, but they have been sent to other practices. A lot of colleagues are getting their masks from the pharmacies. There hasn't been a massive shortage. There has been a problem, an issue in the hospitals, in the public hospitals at the beginning, but they have sorted it out, as far as I'm aware, to most of the hospitals. So there is an issue as to, you have to make sure that you have access to the masks, but there isn't a shortage overall in the market.
Okay. Thank you very much, Dr. Maria. We will go for the next speaker.
Thank you very
much. Dr. Hassan Al-Dhibi, bringing the experience of Saudi Arabia in that field.
Thank you, Dr. Abdullah. It is a great pleasure to be with you here today and to share our experience in Saudi Arabia. And my talk will be divided in focusing in the preventive measures that taken by my country, and then we'll go for my hospital preventive measures and precautions taken to keep the medical staffs and the patient safely. So if you look for the epidemiological status of COVID-19 pandemic status, as you see today, we're reaching more than 2 million of infected people, and the mortality of death is reaching 146.5. Saudi Arabia is almost one of this country and having around 6,300 patients, and death rate around 87 persons were affected, and mortality rate. If you're looking for the epidemiological timelines for our patient, the first case discovered in the Saudi Arabia is in 2nd of March, and this case being traveling from outside the kingdom to the eastern province of Saudi Arabia, and eventually after that the cases were increased, where the government taking the precaution and preventive measures. So the government response include and not limited to closure of Mecca and Medina holy mosques, where you know that it's very crowded area. Then repatriations of Saudi citizens from outside, mobility and transport, flight banning internationally and domestically, and then we forward to curfews when the cases that increased in the numbers. And there is another measure that Saudi Arabia react not just only at the level of the national level, but even though starting to support the World Ophthalmology Congress by $10 million, and as well last night that announced that Saudi Arabia pledged 500 million just to fight against the coronavirus pandemic and effect. So if you back to my hospital, King Khalid Eye Specialist Hospital is a specialized tertiary eye hospital, is one of the main specialized hospital that receiving referral from all over the Kingdom of Saudi Arabia, which is having land area of 2.15 square kilometers with a population of 33 million. Our hospital outpatient services in daily basis, we're seeing from 800 to 1,000 patients per day in different subspecialty. The emergency room receiving 150 patients to 200 with different types of acute ocular complaint. The OR doing 100 cases average per regular days, and we have large training programs, including the residency as well in the fellowship training. So what's happened? KKH has established and implemented precautionary measures and preventive practice towards the current COVID-19 health crisis, and formulating administrative and management initiatives, disease preventive and health safety, clinical service and process modifications, public awareness as well in addition. So the administrative established a core team and key contact that formulated committee for coronavirus that shared by the CEO to meet the daily basis to take prompt precautionary measures and preventive practice against the transmission of the virus. Create a committee, a command centers to deal with these problems and to communicate with the employee, online meetings, webinars, and remote work, and closure of public areas in the hospitals. We have 6 subcommittees that including the infections control that concern with the update protocols, ensure that the compliance and the study all Ministry of Health and centers of Center of Disease Preventions and Controls memos. We have supply and medical that to follow up all the employees on home quarantines and updated screens, clinical to deal with the surgical and clinical activities, reduction, cancellations, and human resources to make sure that all the employee having the good service and safely, as well health education for awareness and educational measures. The disease preventions limited all the entry to the hospital with thermal scanning camera in each entrance to check each person with triage regarding to the symptoms of the patient, if having cough or any fever or that recent traveling from the area of endemic or pandemic of COVID-19. Then we have cleaning and sanitation. Sanitizers and wipes are installed on all and distributed all over the hospital and enforce social distancing. And this is picture from my hospital, how to show the thermal camera and how the disinfections as well the sanitizers were placed in everywhere, keeping social distances to prevent the contacts, and even that the waiting areas of the patient were spaced to keep that. Public awareness, social media for public awareness and health education as we concern with the ophthalmology service all over the wide area, raise awareness and launching questions and answering live stream videos, conduct contests for all employees and their families. The clinical service and process of modifications implemented disinfection protocol on examination rooms and beds after each patient, and preventing direct chatting with the patient at the time of examination, and allowing spacing out of the clinic by every 30 minutes, and slit lamp protective shield as we see in this. Our protective shield is just created internally, and as you see in the picture is that it's very wide so that at least preventing that direct contact with the patients. Wearing masks mostly if there is suspicious patient or there is a coughing, so that it is worn for both sides, the patient as well the examiner. For the clinical workflow follow that we have non-urgent appointments were categorized by the clinical team, routine, urgent, and critical cases. For examples, in the retina, we put certain as based on the international requirement that macula on, closed macula off, trauma to the eye, or one-eyed patient with recent or upset onset of vitreous hemorrhage that need an urgent intervention. Routine cases were cancelled and added to waiting list, which will be rescheduled depending on the resuming service after COVID-19 restrictions lifted. Urgent and critical cases are kept on the clinic schedule. Urgent no-shows cases are contacted to check their health status, respond to a query, and prescribe medications and transportation of the medication to the patient's address home. And if needed, critical no-shows are referral to the virtual clinic, which I'm talking about. The virtual clinic communicate with no-show critical patients patient by establishing secured environment that allows 2 ways live streaming with local ophthalmologists through the Ministry of Health. Both KKH and external ophthalmologists are given the opportunity to book patient and share and store data in the KKH systems. OR, surgical cases, counseling or routine cases, and reserving OR for urgent and emergency cases only, limiting OR and spacing the rooms used for surgery, special anesthesia protocol for all cases done under local or general anesthesia as well. The clinical services as well include and not limited access to hotlines and video conversations for KKH patients, emergency consultation, and any other medical concern. Utilize live streaming of ophthalmology exam to conduct combined teaching round on cases booked for the second opinion. The research, we have training activities were canceled and converted through distance learning via online webinars and live Zoom lectures. Grand round and scientific meeting and global education forum are conducting virtually through the Zooms, and weekly research update on COVID-19 related publications, and as well encouragement of research on COVID-19, as well the ophthalmology practice. So in conclusion, this is what we are doing. It's a lot of protective and precautionary measures, in addition to a lot of services that continued, but virtually and using all the means to help our patient in the Riyadh area or outside. In addition to that, we are giving the opportunity to have the virtual clinic to communicate with our colleagues in every area in the kingdom and provide the patient, especially with the cure few after that difficult for patient to move to the central area. So this is what we are doing, and that's what I would like to share you. We thank God that we don't have any ophthalmology reported cases till now, but still we have possibility at any time. At the same time, we are specialized hospital. We are not really facing the severely sick patient that having the disease or having possibility of the symptoms. So we are a little bit away, and we're trying our best to prevent to have any possible case and to protect our employee. We have all of this, and even though we have videos that elaborated to the media to show how things is running in our hospital. Thank you for giving me this chance, Dr. Abdullah, and I would like to have to answer any question that related to my talk.
Thank you very much, Dr. Hassan. And I know you deal a lot with uveitic patients, and some people believe that those patients are prone to infection more than someone else as they are on immunosuppressive, biologics, steroid, whatever. How do you deal with those cases?
Yeah, as you know that there is certain patients who are at risk, the old ages, the patient who's having comorbidity like diabetes, hypertension, cardiovascular disease, the people with systemic inflammatory disease, patient who is medically immunosuppressive and including uveitis. For this measure, actually, as we tell you that, we communicate with our patient. For the people who is having a bit stabilized for a long time and in immunosuppressive medication, usually we're communicating with them and taking care of them remotely through the virtual clinics and asking our colleagues there to do their routine investigations if they are in immunosuppressive medication. The patient who is quiet, we postponed his appointment a couple of weeks and getting back to call them. The patient who is really having critical situations or unstable inflammatory process, this patient usually give appointment with all the protective and really precautionary measures taken to keep them safe. The patient who is having symptoms of fever or cough or contact with the COVID-19 patient, we advise them to communicate with the internist, rheumatologist, and if they have fever or any symptoms could be like the COVID, we ask them to stop their medications and to have appointment urgently with their rheumatologist. In case of patient already in inhibitors of like infliximab or Humira, this is the patient usually we are taking care and asking to be more cautious. For Bahjat disease who's having really acute attacks or recurrent, we advise to start them in interferon alpha or beta, or this is where the medication it could be and showed that through the published literature is that could be beneficial for such patients. But by the end that we are asking all these patients to have more safety, to keep at homes, not to be mixed with or contacted with the sick people or having the chance to have COVID, and to keep the hand hygienes and to wear masks.
Thank you, Dr. Hassan. And we will go for another experience. Dr. Alessandro from Italy, he will show us the Italian experience. And as you know, each country has its own timeline. and each country start on a time different than the other. And we here to share the experience, and we will be happy to listen to you, Alex.
Hello, Abdullah. Thank you for the invitation. You hear me?
Yeah.
Okay. So this is what I want to try to show in this presentation is not only the experience of Italy, but also the experience of the northeast Italy, the area where I'm based, and from the heights, not, let's go, it's going forward 1 second. Okay, not only from the eyes of an ophthalmologist, but also as a patient. And this is the area we're talking about. So I'm based here in Friuli Venezia Giulia, in the northeast. Is an area that is not so much involved as Lombardy or as Venice. So Lombardy is much more involved than Venice. But proportionally in Lombardy, they have really higher number of deaths, but also a lot of cases more than in Venice than in our place. And this is the R0 trend that is the most important graphic I think we need to look, because we are doing lockdown in this moment in order to reduce the R0, that is the index of contamination that can create each patient. So we want this index to go under 0.5, under 1, in order to keep under control the emergency, and the sanitary service and the hospitals can respond to the questions. This is really interesting to see that in Friuli, my area, Friuli Venezia Giulia, we manage much better the patients. They get quickest and healthiest than in Venice or in Lombardy area, where these areas are much more involved with many cases in comparison with our area. This is the timeline of Italy. The 30th January was the health emergency, international health emergency declaration. 31 declared in Italy. Then we have in 21 February the first positive patient in Lodi area, and 8-9 March the Lombardy, and the Italy the next day lockdown. In between, here was the first steps, the first maneuvers that the central government have done in order to do some rearrangement of the health system and help the hospitals to respond to this emergency. We always have in the next weeks always a higher level of blockage of our activity was blocked. Also the not strategic productive activity, the 22nd of March, and we arrive that in this moment we are doing a little bit better, but the emergency is not under control. What is going on in my area is this, and this graphic shows that we have less cases, but always proportional to the population of this area. The 26th of February, outside from my hospital arrived this tent. This tent was to differentiate the area where was treated and triaged the patient that was suspected for the COVID before the entry to the emergencies area. And then during the next week, we begin to use the personal protection equipment, was introduction in our wards, and we begin to use some patients distancing measures. We try to not have so much patients as before in the waiting area, and somebody, a nurse, was doing a triage of the patients in the entry before they come in. The 6th March was an important date for me, for myself. I have similar symptoms like a COVID patient. I'm an immunosuppressed patient after a bone marrow transplant that I underwent 2 years ago. So I'm in high risk. I went to the infective disease ward. This is a room, a typical room where these patients with suspect disease go until they don't decide if this person is healthy or not. And we need to think that we need maybe also in our clinical practice in ophthalmology, some rooms like that with negative pressure, clean, without much staff, in order to visit patients in case of emergencies. So then we have reorganization of our resources. People, also ophthalmologists, that they wasn't so necessary. They were moved in many situations, many hospitals, in other clinics, in other wards, to help at least with logistic activity the against the emergency of the virus, the doctors on the emergency areas, etc. So another important thing is the 10th of March, we stopped all the type of activity that was not urgent. And it's nice to show you that the 6th of April in the hospital of Udine here, they have a computerized tomography that is dedicated for COVID patients. This is to avoid to mix the ways that they treated the COVID with the non-COVID patients and to avoid the contact of the COVID patients with the other patients. And till now, we are taking more measures. The big problem was the missing of PPE, of protection equipment, and now they are ordering, they are found out how to manage to find this equipment that was difficult to find in the very beginning in Italy, because we didn't have so much material for so much for a big emergency as that. What we are doing here to research the virus is a direct virus research with the swab. And at this point, it's really important. I want to show you that in the University of Udine, the Department of Microbiology, they developed a way to do this without using the commercial available kits that was reducing the availability of PCR per day. And they are able now to do about, in a small area with 100,000 people living in the city, about 2,000 swabs per day. And this is the diagram of the swabs per day performed from the region of Friuli, where is Udine. And at this point, I want to tell you that we have a communication from the central government that say that the antibody research can be used only for epidemiological and surveillance activity, because the risk is that this patient, we cannot demonstrate that these people are no more infected. It was a beginning, and in the beginning, an idea to create to do many of the tests to the population in order to help the people to go again in their own work. But they think that this don't work. And there is also a nice article on Financial Times in the 6th of April that say that the UK government admitted that antibody test that they ordered doesn't work properly. So we know that is a heavy disease, and with a high number of people that are dying because of that. And we know that people need to be treated in this moment before begins this this tempest of cytokines, this huge immune response to this patient that brings to failure these patients that have not been treated properly. And we also know that the doctors are heavily involved in this disease. We pay a lot of dead people. Of 1% of the deaths in 22nd of March in Italy was sanitary, with people that was working in the hospitals, doctors or nurses, etc. And it's not the case that American Journal of Ophthalmology makes an editorial in memory of the first ophthalmology in China that dies from this disease, and report it probably first. And also we need to keep in mind that this disease affects people in working age, and the percents are bigger than what we think. And we need to keep in mind that a lot of asymptomatic patients that go around. So we need to protect, because we are a risk, because we are in the working age, and we can keep in contact also with asymptomatic cases that can transmit to us the disease. So in this sense, it's good if we have the opportunity to protect the patients with a surgical mask. And this is the guidelines of our area. And of course, if we need to assist patients that are suspect, we need to use better masks as FFP2 and goggles and protection gloves, whatever, to avoid any contact. It's interesting. These are the guidelines about PPA of the Venice area. For the maxillofacial doctors, they suggest to use FFP2, but for activity in a smaller distance than 1 meter, surgical mask for the rest of the doctors. I think this is not correct for our category. We are working in about 30 centimeters from the patients, and we are in really high risk of infection. And this is the type of mask we can use. And we need to keep in mind that if we use masks with valves as FFP2 or FFP3, these valves transmit outside from the mask material, and this is risky for the patients. So patients also need to use a mask to protect themselves. Luckily, we are not dentists, and so patients can keep the mouth closed when we visit them, and with the mask protect themselves and also ourselves. So to avoid to do this, that we can see in this image, we cannot visit the patients for 2 meters. We need also to use these shields that we see in any country ophthalmologists use. There are some patterns of the plates that can easily make you create by your own these type of shields. And then we need also to think that it's not only that, we need to clean all the surfaces, because this virus can stay in stainless steel about 2-3 days. And we know that in operating theater, in our wards, this is a material that is all around as well plastic, and we need to use the proper substances to kill the virus, as ethanol or sodium hypochlorite. So what we have done, it was of course to make a social distancing of the patients that arrive in our wards, but also we maintain the activity only of urgent activity that needs to be done between 24 or 10 days. Everything that is deferable has been stopped, except oncological exams that are guaranteed. Intravitreal injections in many hospitals have been stopped because in many hospitals, the operating theater where they do this injection is shared also with other clinics. Some clinics that they use their own proper small operating theater just for injections, they keep doing this. But we need to think also about this, and I will talk to you about this later. So it's a beautiful work that have recently published by Mario Romano. He's a doctor in Bergamo. Bergamo is the area that is heavily involved, famous for the many people dead there, etc. And they try to make an article about how to reorganize our ophthalmology department and how to manage with these patients that we need to stop them. Of course, they suggest to do triage of the patients also by distance, by telephone, by specialized nurses or whatever. And also when the patient arrives, need to undergo temperature measurement, to clean them hands, and wait in an appropriating waiting area with about 2 meter distance between them. And this is the outfit that the outline that they suggest about how to use different types of ophthalmologic diseases, and according to the symptoms or of the situation, how much time can wait the patient, if they can be attended by telephone or need to be booked with a visit in the next, I don't know, 3 months, or is necessary to do a face-to-face visit. And so we need to examine only what is required, and we need to find alternative ways to do this. And also we need to think that maybe we need to protect also with some drops or ozonator or iodopovidine drops when we treat with patients that are infected. And we need to try to do as much as we can indirect ophthalmoscope or in case laser in order to avoid the short distance, long time contact with patients. What he also says is really important that we in big clinics, we need to divide the doctors in two groups. In one group that's involved with patients COVID, and one that is like a backup. And we need to put in this group the patients, the doctors that is in high risk. As myself, for example, I'm an immunosuppressed patient, as I said before, and we need to avoid that people, doctors that themselves are in danger, or the familiars are in danger, to avoid they have contact with this type of patient. And we need to think also about reorganization of activity. For example, I think anti-VEGF drugs, we need to think to move in a one-stop way to treat the patients, to avoid that they come many times in our clinics. They come one time, we see if they are active or not, and we treat them. Now we can even think about a treat and extend or a proactive treatment, but this is another history. From the other side, he also focused the point that we need to use low air inflow and negative pressure operating theaters. Because if we have high pressure flow, high pressure flow in the room, in the operating theater, if there is somebody inside that is positive to the virus, we have a dispersion of the virus in the other colleagues that are working, or in the patient as well, that are inside the operating theater. And we need to know that the dedicated operating rooms for intravitreal injections, in most of the cases, have a laminar positive flow that probably is not so adequate for this situation. So as we know, in the eye, we don't have so much symptoms. They are really rare, the symptoms. We can have some types of conjunctivitis, especially with follicles. And in a study conducted on swamps of conjunctiva from positive people, the positive patients, they found only in 2/30 positive swamps from the conjunctiva. But in any case, we need to be careful with the conjunctiva. Another thing I want to focus your attention is that in this period in Italy and in France, many dermatologists focus attention on the point that there is this kind of microthrombosis in the thumb of young people, of childs. And in anatomopathological exams that have been conducted in North Italy, in the Bergamo area and in Milan, they found out that these patients, the COVID patients that died, they have microthrombs around. And we know that these patients go, they have to face with a intravasal disseminated coagulation. So we need to think that maybe the eye and the retina maybe will be involved in these patients. And we was thinking with the patient from our area, from the area here in Friuli and in Venice area, that somebody thinks that maybe find more frequently patients in the period with branch arterial vein occlusions. And it was also in the Venice area in Treviso, patients with idiopathic retinitis vasculitis aneurysm neuroretinitis syndrome. And maybe we think maybe these patients are positive to COVID, or maybe in the future we will find many of these cases positive to COVID. So we have a nice conversation with Mario Romano, and he confirmed this idea we had, because he found out that these patients that are in the intensive care units and they are in prone position, face down, to help the respiratory distress that they have severe systemic hypotension and hypoxemia, that is inducing some patients central retinal artery occlusion or ischemic optic neuropathy. And the other thing he said, but we all know these patients in intensive care unit, we need to take care about the cornea of this patient and to close the eyelids with sterile strips and lubricate the eyes when we change these steroid strips. So another point was the use of hydrochloroquine. As we know, hydrochloroquine can be toxic for the eye, can give the bull eye retinopathy, or even can give small alteration in the outer retina and the retinal pigment epithelium in the ellipsoid zone that cannot be visible in ophthalmoscopic examination. There are some works that they talk about high dosage delivery of hydroxychloroquine, and there is an editorial for American journal these days that say probably it's safe, and we need first to think about the retinopathy is not a serious concern with respect to the COVID complication that these patients have to face with. But Mario Romano said something else, that these patients, they don't use only hydroxychloroquine, but use also other drugs in combination as tocilizumab or as ritonavir. And there are case reports that say these drugs as well can give retinal toxicity. So they create a protocol in order to follow up these patients in the next year from the baseline when they discharge till 1 year follow-up with OCT, autofluorescence, and any field possible visual fields, etc.
Alex, maybe we can skip.
I'm ending, and we need to. I'm just telling you that we will face with the disease for a lot of time. Maybe there's an article from Science that maybe till end of 2022, and we need to have a surveillance about that till 2024. So we probably need to reorganize our activity, and we need to think that lockdown is not a duty, is an opportunity that the society gives to us, an opportunity to protect ourselves, the fragile groups, and the rest of the society. I want to thank you for their attention. I want to thank also my colleagues that I cannot help them in this moment, and I'm at home since 1 month. Thank you very much, Abdullah, for the invitation.
Thank you, Alex, for this extensive transmission of the Italian experience. And I'm sure we will have a lot of questions regarding that experience in the discussion time. Maybe you can pass to Dr. Murad. Dr. Murad, are you there?
Yes, Dr. Alex, can you unshare? Yes.
Dr. Murad Al-Obathani will transmit that experience of Emirati in that field, please.
Thank you, Dr. Abdullah. It's a pleasure to participate and represent the Emirates Society of Ophthalmology. I'll be sharing the experience in UAE. For those who are joining, sorry, just let me, For those who are joining us from different parts of the world, the UAE and the Middle East, its population is around 10 million. I practice in the capital, which is Abu Dhabi, one of the biggest city among Dubai. I work in Sheikh Khalifa Medical City, which is the largest tertiary hospital in UAE, with a bed capacity of around 760 beds. We have COVID patient in our hospital, which is a slightly different experience from the other speakers who have been working whether in private practice or in eye specialty hospitals only. So first we'll talk about the situation in the UAE. This is the report, the World Coronavirus Meter. The UAE is at the bottom of this list. The list has all the countries, of course. If you look, we have around 5,800 cases. The number is large, but to my knowledge, they are mostly asymptomatic, and it has been detected through the surveillance and tracing of positive cases. This is explained also by the low number of total deaths in the UAE. We have done a very high number of screening in our country, around 750,000 screening tests has been done. We have around 13 centers of drive-through screening tests around the country, where a lot of people can call registers. the priority for the screening has been given to elderly, people with comorbidities, or people who have been in contact with positive cases. This is the timeline for the UAE. So most of the people will decide about the 100 case timeline. We have reported the positive cases since early February or even before that. But the changing boys was the 100 case, which was around March 16. And since then, the cases has been doubled every 5 to 6 days. And up to today, where we reach around 6,000 cases. So from our ophthalmology department, there has been several changes. It has been very dynamic and it has been staged according to the situation. So before we reached the 100 case, all the hospital patient, including ophthalmology, we stopped doing elective cases, actually booking new cases on March 13. And also we canceled any people who are at high risk. Those are with comorbidities or those who have been elderly or any other patient who would need an ICU bed or more intensive care or long stay in the hospital. Soon after, we moved to teleconsultation and trying to minimize people coming to the hospital. The UAE has suspended the flights around 25th of March, and the curfew happened in Abu Dhabi around 26th of March, basically more at night time. More recently, we have more changes in the departments to help basically participating in the hospital, helping other subspecialties, which I'll be talking about in the next coming slides. One of the questions was asked from the participant about testing people. We started on March 30th to screen any people going for the OR, which I'll be talking about. And from 2nd of April, we have been testing anyone admitted to the hospital. So in terms of our ophthalmology department, we basically, as soon as things has been changed, we thought of redesigning our clinic. From the outpatient perspective, we had actually 2 separate clinics. So we segregated these 2 clinics. We allocated one of the clinics to emergency as well as suspected COVID cases. And we have trained the staff, resident ophthalmologists, as well as nurses to use PPE to examine those people. And we have assigned the other clinic for non-COVID suspect and our routine follow-ups, injections, where all the instrument is there. We did as other countries, provided the slit lamps with breast shield protection. And as I said, we trained the staff to use the PPE. In terms of the visit precautions, we have been involved in booking the patient to follow up. So we try to reschedule all patients, and whenever we need to see a patient in the clinic, we ask about symptoms, contact with people who had a recent travel, or patient contact with positive cases. Also limiting the people coming to the hospital, as well as providing social distances in the waiting area, and so on. In terms of the teleconsultation, we started early to minimize the people coming to the clinic. With time, less number of people are coming. We try to have more than 90 people, 90% of people in the booked appointment to be rescheduled or have a teleconsultation. And we have divided the team as the people in Italy. We had to minimize the exposure to people who have medical conditions, including lung diseases or pregnancy. And after that, we have decided to separate the department into 3 teams. And if every team is covering the service for 1 week, while the others can help in other activities, which I will be talking about later. With the as soon as we decided to use the teleconsultation, most of the people, especially the glaucoma patient who wanted their medication, they used to come to take it. So initially we asked them to come to the pharmacy or send someone who is young and healthy to come and pick up the medication. And later on, we moved to medication to home. So basically, this was a service established in our hospital to deliver the medication to home. But because of the demand, we also initiated drive-through medication service. So people will have their medication refilled and they will come to the drive-through to pick their medication. In terms of emergency and inpatient consultations, so since early March, we have decided that the consultation will be answered by the consultant on call to be triaged. And if the consultation from an admitted patient, the consultant will decide if he could resolve this issue over the phone and postpone the consultation if it is not necessary, we'll do that. If we need to see the patient, if the patient is COVID positive, then the consultant on call will put the full PPE and have to do the consultation in the ward. And if the patient is COVID negative, then he will come to the allocated area in Clinic 11, which is the designated area for COVID suspected area. So we will still treat him as a COVID suspect. And also the patient will need to wear the mask. In terms of the ER, the same thing will happen. If patient need to be seen, we will decide if highly suspicious or COVID positive, then patient need to be admitted and we'll follow the inpatient admission. If we don't know the criteria, or we don't know if he is a COVID negative or not, so we will treat him as a suspicious case and we'll follow the order as well. In terms of the surgical management, the emergency case, so we stopped all the elective cases after a week from the start, and we only book emergency cases. And the hospital has decided that any patient going to have a GA or any surgery will need to be tested for COVID because of the aerosol risk of doing a GA. So and if there is any emergency case that need to be done within 24 hours, then the OR staff will treat it as a COVID case. They will put the hazmat suit, everyone need to do that. We didn't have to do it as an ophthalmology, but I know that other departments have done this. In terms of the other categories, that if there is a case that could wait more than 24 hours, so we send an urgent COVID test and we wait for the result. And based on that, we decide. We have two categories of COVID test. One urgent, that the test need to be done within 24 hours. And the other tier 2 is within 48 hours. It depends on the urgency of the case. And from the ophthalmology department, we follow the American Academy of Ophthalmology procedure list, that these are the cases which would need an urgent surgery. So that's from the ophthalmology point of view. And as an ophthalmologist and most of the surgeons who have been freed since the elective cases has been canceled or postponed, we have been involved in helping other departments. We helped in healthcare worker screening program. There was a big demand for the healthcare screening program in our hospital. So we categorized those people who are high risk, medium, and low. The high risk people are any healthcare worker who is exposed to COVID positive during aerosol procedure, and the healthcare worker was not wearing proper PPE. Medium risk, if the patient, if the healthcare worker is exposed, but the patient was wearing a mask, but the healthcare worker was not wearing proper PPE. The low risk are those healthcare workers who are wearing full PPE and the patient was wearing a mask. And most of the healthcare workers supposed to be in low and maximum to a medium risk. And then we follow the CDC guidelines of high, medium, and low risks and decide everyone will get screened. but those who would need to have a repeat test or exclude them from work duty if needed. And as I said, a lot of ophthalmology, especially our resident, has been volunteering and helping other departments. These are the pictures of our resident volunteering in the healthcare worker screening, as well as calling. They had a great help in calling the COVID positive patients. So helping to identify them, trace the contacts, as well as allocate them to a hospital if they are symptomatic and they need admission or investigation, or just quarantine them in a hotel or other ways of or home if possible. Along that, there are several ophthalmologists who also helped in other departments, including emergency and COVID wards. This is the first ophthalmologist in UAE who has been in the COVID ward, Dr. Habib Atimadi, our head of the department. He was volunteering to be the first one. Although the internal medicine team were not very impressed because he was missing his shoe cover. But their duties is to be supervised by internal medicine team. And he has been assigned a couple or 3 patients, basic registrar job, going through the notes, reviewing the labs, documentation, putting the order, follow up on the results, and mainly telecommunication or teleconsultation with the patient. No need for the doctor to see the patient unless there is a necessary thing to be done. So the goal for this is for the surgeon in general to be able to manage COVID mild cases and understand when to refer a patient if they deteriorate. If the surge happens and internal medicine had a shortage, there will be a backup team who could help with managing mild cases and be able to identify the high-risk people who would deteriorate quickly and refer them to high-risk COVID wards. The last thing, I read this article in a newspaper, or a link has been sent to me. It's interesting, talking about the new normal. It seems that the COVID-19 situation will not get easy in the next 6 months. So I believe, like surgeons or ophthalmologists in general, need to adapt to a new normal. We don't know how long this is going to be, if there is going to be a vaccine, or if there is going to be a new treatment that will solve the COVID situation. All what we have been doing is, for the time being, is social distancing, hiding in homes, but this will last longer. So the take-home message from this article was the doctors need to participate. It's our moral and duty to help the community and participate in this crisis. And I think as an ophthalmologist, we have the knowledge, we have the education, we are being trained as a physician to help in this situation. And I think that's it from my point. I thank you for the listening, and thank you again, Dr. Abdullah, for inviting me.
Thank you very much.
I think we're gonna miss these LASIK and corneal transplant for a while.
You're gonna regain it. They are waiting for you, don't worry. Thank you, Dr. Murad, for this talk. I think we will pass for the sake of time. Then we'll have a discussion and questions at the end. Our next speaker is Dr. Roberto.
Thank you very much, my friend. As you know, but everybody knows, we have been good friends for almost 12 years right now. So it's my pleasure to be here this afternoon and share some brief comments. I have been updating the presentation while my previous speakers and colleagues have been very elegantly showing what's the situation. So about the Spanish experience, you are all familiar with these graphs provided by Financial Times, by John Murdoch in this case. And there we are, Spain, close to Italy. So we are not doing very well. Talking about ophthalmology, we also have to consider the economic impact of this situation. So in Spain, there is an increasing number of unemployed people. And this has a lot of social and economical implications in terms of healthcare, both in the, obviously in the public setting and also in the private setting. I took a look at this stock holding index from Spain, and it's really terrible what is happening, not only in Spain, but all around the world with all these things. At times we complain that we have no safety equipments enough to use, but we have no money to buy them also. And this is going to be increasing. At this point in Spain, there are 24,000 healthcare professionals infected. This means that almost 10% of all the infected population is a healthcare provider, both nurses, hospital staffs, doctors, etc. So this means something. This means that we have a limitation to access an appropriate protection to fight this pandemic. Also, there is no wide availability for testing healthcare professionals. So this data should be clearly underestimating the total number of cases. And this is also a problem. In Spain, we have barely a 50% and 50% public versus private setting in terms of economy. You can tell what is happening with the private setting. We have a lot of temporary employment regulation, which has taken about 4 million people included in that situation, coming from the private setting. So these salaries should be partially or completely taken care by the public government. Obviously, in addition to this, we have limitation to masks, gloves, these very basic things. And there is still a problem to get them here. So now what? And that's the main question, now what? I think we should, as my previous speakers elegantly showed, we have to think, we should think outside the box. We still have to be the feeling that we are looking for heroes. But there's no hero in this story. This is a terrible situation. And we try to provide the best care to patients and also to ourselves, because otherwise we will not be able to take care of patients. We should be looking for good ideas, not heroes. Please consider, all of you, that we may never go back to normal situation, and rethink your position and options. Clinicians and patients should get used to safety procedures. We will be wearing masks for a long time, probably forever. We will be wearing gloves the entire day, maybe forever. And with this in mind, as a retinal physician, intravitreal injections should be continued in most cases into a treat and extend regimen. All surgeons may only do surgery. This means no combining clinics and surgery, because otherwise they lose the place for decreasing volume of patients every time they go for surgery. And as previously said, it is an excellent option to perform a pre-visit questionnaire for every single patient and caregiver or accompanying person. Anybody with fever, symptoms, recent exposure to COVID should not be seen in a normal setting. So I wanted to be brief. I have removed a lot of things, but I hope, my friend, that this was clear from my side. And thank you very much for having me today here.
Thank you very much, Dr. Roberto. Very, very nice talk and pinpoint on the really information that we need. It's shocking that we have 10% of health workers that get affected by the disease. We thought it more softer than that. And I think elaborating on the importance of really taking care and take it serious is an important. Just ask a question. It's two questions actually. Number one, if the time go back again, are you going to change part of your strategy? Because maybe Spain, Italy, they face it at the beginning, and they was not having enough time just to analyze and having guidelines and plan properly for managing that situation. So are you gonna change some of your strategy that done already in the past?
Absolutely, yes. This is a political issue. Nobody in the world was ready for this. And this is especially true for countries like Italy, Spain, and now we are seeing that in UK and the United States. We cannot underestimate this situation. We are aware, thanks to the science publication, that you are all aware of it, that these terrible times will be back. And we will definitely be back by the upcoming winter and probably next year for less period of time. So we cannot relax our strategies in terms of self-protection and protecting our patients. We don't know how long this will take. So that's why, Abdullah, I was mentioning, be careful with dismiss patients with intravenous anti-angiogenic agents treatment, because we don't know how long they will be home. Expand your schedule. Stay there for a while, more than usual in your clinics, and have as less patients as possible each time.
So what I understand, I understand from you that intravitreal injections, you will inject them, isn't it? Even diabetic macular edema. It's not only AMD.
I'm talking about mainly AMD, but also for diabetic macular edema. I have been patients treated last January or February, waiting for the good time to come back and make them see better. We all know that this is not a terrible situation when talking about macular edema due to retinal vascular diseases, because we can improve vision later. We cannot do that with AMD. We will be losing a significant amount of vision. So a good point is to individualize, call every patient as a doctor. You are responsible for that. Talk to them, how they are doing. Have they any symptoms related to COVID or any exposure? And make sure that if they need to come for the injections, you wait for them. I don't need to test pressure, vision, OCT. This is not a good idea to have them rolling around the clinic. I wait for them, they get inside my clinic, and they go straight for the injection and back home with a follow-up visit.
Thank you very much, Dr. Roberto. We will launch a voting for the attendees to see how much part of their job get affected. So everyone on the audience, we're glad that you are here. We run now on launching the polling. Can you please vote how much percentage of your work stopped because of COVID-19? Okay, so we will stop the voting now. And this is the result. So 90% is about 50% of our ophthalmologists get stopped by 90%. 18% is 50, and this is the other of statistics in front of you. Thank you very much. Now we will go to our nice talk from Professor Ashraf from Egypt, transmitting to us our Egyptian experience. Prof. Ashraf, please. So now with We can start now with Dr. Ashraf from the beginning, please. Can you unmute yourself, please? Now we can hear you. You can go.
So I'm a veterinary surgeon from Alexandria, Egypt, and I'm dealing with real emergent cases. So that's why I cannot stop my work. But at the same time, I have to protect my patients and myself and my assistants. Thanks God, the situation in Egypt is not that bad. We have reached around 2,500 patients, and the death number is around 183. But we hope that in the next few weeks or days, the situation is still stabilized to this level. I accept new cases in my private clinic for examination and management as long as they are urgent retinal conditions. I'm continuing my work in the university online through preparing narrated lectures for under and postgraduate students, operating only emergent and urgent and emergent cases, and canceled those cases who are not so mandatory. And if the patients are from outside Alexandria, I may send the files for one of my colleagues to examine the patients and get me a report about him. We use surgical masks, goggles, and protective face shields routinely during examination. We prefer a no-touch technique, and thanks for our tools like the OCT, the OCT angio, which help us to never touch the patient. And again, I'm trying to use more and more the indirect ophthalmoscope because it gives me a space between me and the patients. Ongoing medical cases like intravitreal injection for age-related macular degeneration, we do it. Other non-age-related macular degeneration, we also give an injection, but we try to increase the interval, the so-called treat and extend regimen, with looser criteria for activation. We are more relaxed with diabetic macular edema. If there is no established fixed schedule, it may be continued, but we can inform the patient that it is not a big problem if one or two of the injections are skipped. This usually does not cause permanent damage. We operate on the following cases like open globe injury, acute endophthalmitis with severe visual loss, acute retinal detachment, retained lens fragments, expulsive choroid, dense vitreous hemorrhage in a monocular vitreous patient, vitreous hemorrhage in which a retinal tear is suspected, like what we call bridging vessel syndrome. And this is actually one of my cases which came during the Corona era, and I have to operate both because this is a very simple upper temporal retinal attachment with a single break, and I have to go just to buckle the patient and reattach the retina. If I'm going to skip this patient, I'm going to cause him permanent damage, as you all know. And by just a very short procedure, I can save his sight. Again, cases like combined tractional rhegmatogenous retinal detachment, which is very common here in Egypt, to have patients with long-standing PDR, and then all of a sudden they lose vision because of a rhegmatogenous element we have to operate upon. And this patient in particular have low immunity because they have very long-standing diabetes with all the complications of long-standing diabetes, which decreases the immunity. So you have to be careful with dealing with them. Again, choroidal neovascular membrane with hemorrhage, like this case, and we have to go just for gas injection and intravitreal injection of anti-VEGF. We save these patients because they can regain some vision, and if you leave them, then you are going to harm them by losing their vision. But again, this is my picture using the personal protection Google or equipment during the examination and before going to the OR. One important thing which I had realized, that there are applications on the Apple and the Play Store which you should encourage your patients to download, like the Amsler Grid, and you can depend on that and depend in your patient to not come to the clinic by just following up like macular edema or choroidal neovascular membrane, but you have to instruct him to do it using his reading glasses, doing every eye separately, and then he can report to you what he can see on this distortion on the Amsler Grid and send it to you. And if he has really distortion, you can go and examine him or do for him an OST or OST angio. Again, there are some other tools which the patient can download in his phone, on his smartphone, and examine himself before coming to your clinic, like smart optometry, which have color vision testing, visual acuity testing in a near real dependable way, so that you can screen some of your patients. Again, what we had realized during this crisis, that we have to train in a very good way, our young generation, because all the people on the front line facing and defeating the corona were the young Egyptian doctors. The old ones like me didn't go for the front line, even if I was an internal medicine or emergency. And that's why we have a training school in Alexandria, and we did start it in March, but we were not able to finish it because the corona crisis. But we have to take care that we have to train our young people, because they may treat us at one point if we have to go for that. Again, the economy impact on ophthalmology practices is very difficult, because like this expensive OST angio machine, we are going to be able to get these machines in the near future, especially if you are depending on private practice and on loan. You don't know if the income of this machine can pay for the loan payment. So you have to think about that thoroughly. And you may think about buying new instruments only by overdraft if you have the money. Don't go for loans. Again, like the very fantastic 3D surgery, but you have to pay for that. If that is by overdraft, get it. But you don't have to go for loans, because now our income had dropped to almost 10 to 20%. And if you have to pay for this expensive machine, you are running in real trouble. Again, you have to support your workers and your assistants, the workers and the nurses in your private practice, because these are your soldiers. If you are going to lose them, and this is a real problem in Egypt, then after the crisis, we are having real problem in finding these workers, which are very important for us, who are trained in high-tech machines, the nurses and the workers in the OR. If you are going to lose them during that time because of the financial crisis, you are going to lose some of your important soldiers. But we have some good things about this pandemic. We stay at home for a long time, having dinner with family, sleeping enough, enjoying doing some sports during that time, which was not available during the regular time. And the pandemic is reminding something else, to slow down all our work after the crisis gone away, and spare more time for ourselves and for our loved ones, to put aside the little problem, to stop wasting the world and depleting it, to feel the value of freedom, and to hug the loved ones. And really, I thank you all, because I had the chance of the corona and of this webinar to know all these gentlemen and gentlewomen during this webinar. Thank you. Are you muted? Dr. Abdullah, are you muted?
Dr. Abdullah, you are muted. Unmute yourself.
Okay.
I mute myself just to show you the fairness between all of us. We launch a voting for the audience, please. You can vote now and choose your place that you are seeing this webinar. During that time, Prof. Ashraf, do you keep injecting the diabetic macular edema? Do you keep injecting them?
If the patient is scheduled for that, I do it, because I don't think that he does have a real problem of going for intravitreal injection. We didn't hear anything about the danger of going for injection, as long as we are using the personal protection equipment and the patient have a mask or whatever he gets for keeping him from infecting me.
Okay, thank you very much. This is the result of the poll. We will show it to you before we start share the result. So this is the result of the second poll. We will go now with our colleague, Dr. Saumil from India, to transfer to us the Indian experience in that field also.
Yeah, so I have loaded my presentation. Can everyone see it?
Yeah, we can see it. You can just start. Very good.
So a lot of my colleagues have discussed very good points, ophthalmology pertaining. My topic, there will be a slight deviation. Coping with COVID, the ingeniously indigenous Indian way. I'm going to be showing a few things that we do specifically as Indians, especially because we have our own problems which are different from the rest. I'll give you an example. This is a typical weekday, busy day in Mumbai, and this is the population overcrowding that we have. To put this into perspective, there are 1,300 million population versus 60 million in Italy. It is 21 times that of Italy. And if Italy has had around 22,000 deaths, our death rate going by the same statistic would be around 500,000. So deaths, putting this into perspective, 500,000 is 5 times the entire population of the town of Udine, from where we have Dr. Alex as the invited faculty. But what we have had so far is just 452 deaths as of now. Yeah. So 452 deaths so far over a month. In our country, more people die on our railway tracks over a month. So in fact, as far as the death rate is concerned, we are in the negative. Apart from overcrowding, we have other problems like poor health infrastructure, paucity of ventilators, doctors, and healthcare workers. More importantly, what we have in our country is ignorance of our people, and born out of ignorance is what we call as defiance. They will not follow. The typical term that we use for those people are what we call them as COVIDians. But we are not here to discuss our problems. We are here to discuss what our strengths are and how we are battling with this COVID disease. So the first important strength of ours is crisis management. You saw those crowded trains a little while back. We've converted majority of our trains, which have now been stopped, into intensive care units, all of them basically equipped with a ventilator. And when I utter the word train, it basically means compartments, and compartmentalization or isolation is what is the need of the hour for our COVID patients. In spite of the crisis that there is, our ability to help others is very, very important, and that is what keeps us going. We are exporting a whole lot of HCQs to first world countries. And the third most important strength of ours, which I will be concentrating on and will be the highlight of my topic, would be cost-effective innovation. Whatever available resources we have at our disposal, using them to make the best of what we can. If you see here, all of them are cost-effective alternatives that we have adopted to take care of a crisis situation. So what have we done as far as treatment innovations for COVID-19 is concerned? Because our country is short of mechanical ventilators, if you cannot use a manual ambu bag, you devise a very simple machine that pumps in air from the ambu bag. You can control the rate as you see here, as well as you can control the intensity, pushing it less or pushing it more. You can release pressure from the pressure valve. And as you see, it is completely remote operated either by the doctor or can be even given to the patient in order to sound an alarm. The other important innovation, a cell phone program connected to a small portable ventilator. You see the size as compared to a normal ventilator. The program runs via an app which is connected to a portable ventilator. This is less than 3 kgs and costs around 500 euros. And you can take this home actually. And when you are on home isolation on ventilator, it is the best form of isolation that is possible away from our wards. It will not overwhelm our resources. So coming to personal protection in cost-effective innovation, I think most of the people have seen this video. The simplest form of a face shield is to use a Coke bottle, a plastic one, remove the plastic off, and it is self-retaining right on the face. So we've done slightly more refined version of it. We take a normal plastic paper and we punch 2 holes at both the ends. We put a face mask into it and we let the face mask strings go through those holes such that we have a mask come face shield together. And all we do is tie this face mask around our faces so that we can accomplish both the purposes. Another important innovation is using a simple hairband. Through the same punched out holes in the plastic, we use the hairband as a self-retaining face shield without a mask. You can wear an N95 mask inside. This also highlights a similar innovation wherein you put it in a cap on the left side and you have a face shield ready along with a cap, and on the right side it shows a hairband. Now this is a very, very interesting innovation. If someone can guess what this is doing, this is what we call as arm restriction therapy. More often than not, it is not the virus that gets transmitted through the mask. The act of putting and removing mask is what causes the virus to get touched around the nose and the facial area very often. So this innovation is putting a tape around the elbow such that any flexion movement is going to give some catch into that. And we can probably realize unconsciously as we are taking our hand towards our mask that there is a slight catch there and we should stop ourselves. As far as ophthalmic clinic design is concerned, a lot of pointers have already been given by my colleagues. Important ones being to have a separate wash area outside the registration area, to have one single waiting area which has vision testing and triage area, and trying to disperse of patients from this place itself. This entire unit should be housed in only one block, such that if a COVID positive patient is found in this, you can keep this for sanitization and go on to the other block. So one block opened at a time is probably the rule. Now this is a very practical innovation wherein you spray sodium hypochlorite via a shower or in the form of small mist on any person that is entering the OPD, and that will give you some protection in terms of disinfection. You can spray this into the OPD as such as a means of sanitization, which is this is what I call the more ingenious form of fumigation. You leave a gap between 2 patients by consciously putting a barricade in between 2 patients on a chair. Now, this is a very important questionnaire which patients have to sign before they are let into the OPD. I have highlighted the ones in red that are necessary to be asked, which shows whether the patient has traveled from a COVID positive area or has some form of symptoms. This important sentence is not to be neglected. I do not hold the healthcare workers of my hospital responsible in any way if I were to contract COVID-19 subsequent to my eye checkup. This will also be a deterrent for all those non-emergency cases who come for a routine checkup to not come. Secondly, this one important clause I always like to tell my patients, that if I feel that the patient is symptomatic for COVID, I am entitled to submit his details to the concerned authorities and let them decide on whether the patient needs to be tested or not. The other important thing, only one relative allowed inside the clinic. Now, we all have seen this slit lamp shield that is there. Our innovation here is using an X-ray film, a used X-ray film, to act as a slit lamp shield. They are anyway to be disposed of and would not cost as much. Similarly, for indirect ophthalmoscope also, we have a plastic shield which we rest on the eyepiece and then with a two-way tape stick it on either side when we are doing indirect ophthalmoscopy or laser. Now, the important thing here to note that our OPDs are converted from air-conditioned areas to well-ventilated areas where the windows are open. And you see a table fan that is blowing on the patient, not away from him, so that whatever aerosols are emanated from the patient are dispersed out. Whenever you're doing tonometry, see to it that you don't use an air puff tonometer because it involves aerosol blowouts. Try to use an eye care tonometer or some such device. Obviously, you need to sanitize the slit lamp after every use. Not only that, you also need to sanitize wherever the patient has touched. Now, this is a very important innovation. I mean, it's not an innovation, but it's an important measure that we've taken, is to use ultraviolet light in the night when the patients are not there in an empty OPD for 3 hours, and that is the best disinfectant that is possible. A minor innovation of this is an old fridge or a used refrigerator, which otherwise is useless. You can put those UV tube lights along with formalin tablets inside, and you can disinfect a whole lot of small time personal belongings like wallet, phone, ophthalmoscope, watch, even masks for that matter, and so on, and reuse them. As far as personal protective equipment is concerned, there are a lot of questions on this as to up to what extent we should dress up. And this is what I'm going to highlight. There are 3 levels actually which our government has given guidelines for, as to from the most basic dress up to the most astronaut-like dress up. So this is based upon the fact of this COVID RT-PCR test, that under the best of situations, only 60% of them would be actually tested positive, which means if 80% of them are asymptomatic carriers, 40% of them are likely to be falsely negative, which means they have the disease, but even the RNA PCR, RT-PCR is not able to pick it up. So the dictum is that treat every patient as a COVID positive patient and try to use these precautions. Now, all these precautions are very good as far as we being inside the clinic is concerned. But as I showed you the photo before, what when we step out of our clinic, or what happens when the lockdown is lifted? Even if we have a partial lockdown and deter these people from crowding in the local trains, let's say we reduce this by half, still it is overcrowding. So when we are in public spaces, can we do we still wear PPE? It's not practically possible. So how do we protect ourselves post lockdown and when in public? Because in the clinic, we can probably wear PPE. What happens when we go out? So this is a very pertinent question that was asked by a patient to me. Before every elective surgery, I have been advised by COVID for your protection, as in the doctor's protection. But what guarantee do I have about my protection from the doctor or the staff? Has the doctor or the staff been also tested for COVID, considering that most of them could be asymptomatic carriers? So we need a test. We can do RT-PCR, but in our population, it is an expensive test. It is not available all the time, and the success of it depends upon elaborate taking of the nasopharyngeal swab, which sometimes the technique may fault and we may not get a good result. So mass screening and testing method that is cheap, you can self-test it, takes only a small blood prick, and the results are instant. You don't have to wait for 24 hours, especially when you have emergency surgeries. Now, the test in question here that I'm talking about is a total antibody test. As against RT-PCR, you see that the sensitivity of total antibody is 90 to 100% beyond 8 days. This is very important to note. Now, when the test of antibody is negative, it does not give you much information because you still have to do RNA PCR. And if that also comes negative, the guideline is that you are not exposed as yet. If you are in the high risk age group, say above 50, stay at home, come lesser in contact with people, maintain good social distancing, and dress like an astronaut when you have to. But let's say if the test is positive, the positive test can be of 3 types. The first is only IgG positive. IgG positive means you've had a past infection, you are safe, you can work as much as possible, and you needn't wear any protective equipment. The second one being IgG and IgM both positive. That is approximately you are between 7 to 14 days through to an infection. You wait for another 7 days and then you are safe to move around without any personal protective equipment. If you are only IgM positive, means you are fresh into infection. You wait for a minimum of 14 to 15 days, repeat the test, see that you are only IgG positive, and then you are out to work without any PPE. This gives you, this test, unlike RNA PCR, gives you a very, very important statistic that you can follow, is the percentage of subclinical infection that our population has already acquired. So that gives you the percentage of herd immunity that is already there. If the herd immunity is reasonably good in a particular population, that population can be released from lockdown. So that I feel this test is basically the need of the hour. The test is still in pipeline. I don't know how many centers have implemented. It's just come to India. Our Indian Council of Medical Research is trying its level best to procure it. And this I think is a light at the end of the tunnel if we want to segregate our population into positives and negatives. Thank you.
Thank you very much, Dr. Samuel. Very nice inventions and sharing of an idea. Before I give you some question, I will run this poll. The poll saying, do you know a doctors who has the disease? Either doctors or nurse or technician, any one of your friends that you know him, work with you, that he has the disease. Please, for all the audience, we need you to vote. Okay. So we will share the result with everyone. This is the result, guys. So 28% of the health worker, they know at least one who has been infected with that disease. Dr. Samuel, I have a question to you, actually. India is very populated countries, and with the public transport, with the lifestyle, they have to get closer to each other. What's the solution? How you manage?
So that is what I was trying to exactly highlight in my presentation. We are a densely populated country and we cannot have something like a partial lockdown. Just now we are in a state of complete lockdown. If we go for a partial lockdown, it is still going to be overcrowded. So what we can do is have intermittent periods. Let's say complete lockdown for about 15 to 20 days, then work for another 20-25 days and go for another lockdown. That is the only way by which we can stagger the graph and flatten the curve. Because if we go for a complete release after a lockdown, we are going to have a sudden spike in the infections. And what mass screening I was referring to by way of antibody testing is the best way possible, because those who are already positive IgG for the disease by a minor pinprick, you can probably do this test even at home and probably take the results out in public. These are the kind of people which should be free to move around and do their work, because these are the people who are at the least risk not only of getting the disease but also of transmitting the disease. So I feel that is a way out for India.
Thank you. And last question, I know you work in a private section also and you have your own clinics. How does the disease affecting you? Your percentage of work and the employee?
90% of my work is down. Only 10%. I'm dealing only with retinal emergencies. I'm a retinal surgeon, and I do give injections as and when I feel they are required on an emergency basis.
Okay. We will open the discussion, guys. Maybe Dr. Alex, 2 minutes for comment or sharing an idea. Alex is not there. Okay, so
Alex?
Dr. Hassan,
Yes.
can you
Yeah.
please share what you want to share us?
Me, Abdullah?
Yes.
Yeah, I would like to thank you first for this really an excellent sharing experience, especially from that European countries, Greece and Italy and Spain, where they have really nowadays the outbreak is huge and they face a lot of patients with this. And our colleague from as well from India that give a lot of innovations in what he's doing. Actually, prevention is better than cure. So we don't have real treatment for the disease by the time being. We are doing our best to prevent, to get the infections either from ourselves to our patient or the opposite. There is one issue that we have a lot of things that controlling our practice. There is a private sectors and there is really impact financially in these issues. And there is a lot of questions about simple procedure that, as you know, that we're depending in the injections inside, especially the nowadays for DME as well for AMD. I think we have to be thinking too much nowadays because we don't yet reach the level of know the disease exactly, how things is going, what is the best measures to prevent the cross infections between. We have the PCR, which is in the early give you false negative test, and we have the IgM and IgG, which is little bit the price is higher, so we cannot do it for the measure. So we have two issues: which injections you have to go in this times before the peak. The second things, which patient you have to make the test available for him. I received questions regarding to injections. Usually these times we are demanding to give the critical patient, which is the AMDs, to continue their scheduled injections. DME, we're calling and looking for the patient, what are the, is it monocular or non-monocular, and then accordingly. For the emergency cases that threatening the lesions, it is definitely need to be done. For tests, which patient you have to test? Is that any patient going for surgery going to do the test for him or not? Or depending our questionnaire for this patient, is it highly really good index to know index of suspicions or not? This is where we think that we have to look for.
Okay, so I think elaborating on the injections, most of the guidelines, whether the French or the Dutch or the German, UK, American, they speak about the AMD.
Yeah,
So
but what I heard today from our colleagues from different, they are scheduling patient for the injections. DME.
I believe this is a correct behavior actually, because you don't know, are you in the beginning of the peak, as Roberto said, or you are at the end of the peak. So if you said, okay, we will delay the patient for 1 month, 2 months to see what's going on. No, we believe it's a long-acting pandemic. So if we said,
But this is where we have to go back to the epidemiology surveillance and the people who is concerned that they give us the feedback where we are.
So if you are now, Dr. Hassan, are you going to keep injecting diabetic macular edema if he came to you today?
Came to me today?
Yeah.
If he's arrived to me, this is another issue. But calling patient to come, this is the issue.
Okay, Dr. Maria, are you going to inject the patient if he came to you today, if he has diabetic macular edema?
No, I would not. Not today. But Greece has been lightly affected so far, so I have the option to review them in a month or two, hoping that it's going to get better. If I was in Spain or Italy, I may have a different strategy about it, to be honest.
Okay, Dr. Samuel, are you going to inject him?
if I can you just get the question back? Are you talking about any
Yeah, the question is, if you have a diabetic macular edema patient and he came to you today, are you going to inject him or delay him till see when this pandemic is going to finish?
Yes, I understand. So we have two situations mainly. Choroidal neovascular diseases are unforgiving. Diabetic diseases don't progress so rapidly. You have a certain grace time and you can wait for it. My way of telling the patient is, do you feel that there is a significant decline in vision? Let's not see what the OCT is saying. Let's see what the patient's symptoms are. If the patient does not feel that he has symptomatically worsened from the previous injection, then probably I can tell him to wait for a little while, control his systemic status, and then take it later on.
Okay, so your answer is going to wait. Dr. Roberto, are you going to inject him?
100% yes.
Dr. Alex, are you going to inject him?
What I want to tell you that what's going on in Italy, in the hospital that they have shared operating theaters, they don't do no injections. They stop most of them. So they do the injections only in dedicated rooms. So they do both of them.
Yeah, I agree with you, Alex. But I think we should differentiate between the shock effect of the pandemic and with the second phase of the pandemic, in which we have a guidelines, we start understanding what's going on, and we start evaluating the risk and the benefit of injecting.
But your concern is the risk for the patient because he's high risk, because he's diabetic, so he can get infected, or he can infect you, or what we need to prefer, because if we have a dedicated room that do only this type of activity, this type of activity can go forward as before.
Yeah, but you'll bring the patient to come to you. Dr. Roberto?
A very brief comment. These patients are allowed in Spain to walk out with a dog, to go to the supermarket and buy food. Why should they not be able to come to get the injection when they need it? This is just a thought, right? They go outside. So again, very important, the pre-visit questionnaire. Any suspicion, don't come today. Go to your comprehensive doctor, the general doctor, talk to him about your symptoms or whatever. But
okay, Dr. Ashraf, you said you're going to inject or no?
Yes, I'm going to inject because I think that we don't know exactly when this crisis is going to finish. Some say that it's going to be by the end of the year, and some say it's finished.
This is also my belief, because at the same time, you don't know when it's finished, but at the same time, we should classify in two ways. Number one, is it a hospital that accommodate a COVID-19 patients, or it's a private clinic like it's an office and patient came to you for retinal consultation only? This is number one. And number two, is the patient having the loading dose number or having the maintenance dose? Because there is a difference with the effect. So I approach those patients as I start believing. I stopped my injection till now, but I believe when I'm thinking deeply, I would inject them. Why I shouldn't inject them if I'm going to inject the AMD? This is what I thought of. He was trying to say something, Samuel.
Yes. So when I said that I will wait for some time, I didn't mean that I will not inject. I will definitely inject, but I will not be in a hurry to do it.
True.
You cannot,
for a diabetic macular edema.
Yes, for choroidal neovascular membrane, I will not wait at all because it's unforgiving.
It's
diabetic macular edema is not that acute.
Yeah, so, but at least
eventually.
Dr. Hassan.
Yeah, as you know that, as we heard from our colleagues, that we are gonna to schedule these patients up to the situations. But put in your mind that we are still in the learning curve of this outbreak. We're not yet reached the evidence-based practice, how to deal with the patient, how to protect ourselves, how to protect our patients. It might be a lot of factors that influencing our practice. I'm going to inject or not inject. I wouldn't like to expose any patient with risk factors and comorbidity and call him back to come to the hospital to give him the injection, unless I have heard from my colleagues from Emirates, they separate the practice. They see the clinic. COVID patients where they are being kept in certain area, and they have teams that divided between non-COVID patients And could be this is used, you know, as by the time being for this urgent patient, like AMD patient, like monocular patient having decreased vision with diabetic macular edema recently. This is the way that, so I think so still we are in the times that we are not reaching the maximum protective evidence-based measurement that we do.
That's what we try to do now.
And I'm sure within a couple of weeks from now, we'll have all this settled down.
Okay, I think just for information, we was having more than 680 registrant, and till now we are at the end of the talk. We have still more than 241 or 42 attendees. We will launch the poll. Then we will go for Dr. Murad for comment. So the poll is saying, do you inject diabetic macular edema in a COVID-19 pandemic? Please, for all the audience, vote.
Abdullah, please.
Yeah.
While we wait for the results, I have read several questions about the spreading the virus through the tears.
Actually, this is a question for Dr. Murad.
Okay.
Just to make a comment, I apologize before, but I cannot see in Zoom, as I told you, Saumil. I'm watching him in YouTube with 10 seconds delay. So I'm sorry before I interrupt the conversation, if he was attending to speak or whatever.
No,
but I couldn't see him.
It's okay. Dr. Murad, maybe you should comment on the...
Before commenting on that, just adding a comment from my side, from anterior segment person about the injecting diabetic people. As you said, diabetic are, we should, as an ophthalmologist, think of the patient as well. Bringing a patient to a hospital where there is a COVID people, and it depends also on the number of cases in the country. Like if the pandemic is at the peak, there is more cases still undiagnosed rounding around the hospital. So you should also take this into your consideration when you decide to bring the patient for outside of his home, depending on his age, comorbidities, and so on, and looking into as well as his visual function before deciding to bring him to the hospital.
Okay.
And then I have a question for the retina panel. I haven't had the experience yet, but let's say we have a patient with a retinal detachment. As I mentioned in my talk, we screen those, any patient going to OR, we screen them for COVID-19. And in case this became positive, and we know that recent publication showed that the virus is present in the tear film. So how would the retina specialist do, especially that you guys use, let's say you decided not to do it under GA, so there is no less aerosol, for example, but you are still doing air fluid exchange. You are also at risk of creating aerosol environment when you're doing the surgery. I wonder if you could answer this, or if you had any experience for those from Italy and Spain.
This is very good.
In Italy, we do direct research of the virus. We do PCR. And the PCR, normally, we have the results in 6 hours maximum. Personally, I had the results of myself in 6 hours. Maybe in some cases of big screening of the population, they have delay, but they can guarantee these 6 hours for the emergencies. So I think these 6 hours of waiting also for, for such a type of emergency is acceptable and keep you safe. And it's not only to keep yourself safe, but keep safe the area, because the risk is he can infect all the operating theater and all the way he moved inside the hospital, this patient.
Okay, thank you, Alex. Just to show you the result of the poll of the injection in a diabetic macular edema, then we'll go for Roberto for his comment. Do you see the result? Okay. So that's it. 34% will keep injecting and 44% will delay. Okay, Dr. Roberto, you want to try to say something or comment on conjunctivitis or whatever?
Yeah, about the tears I was considering before, right? there was at the beginning, as mentioned previously, we are learning things. It was completely prohibited to do pneumotonometry for our patients because of this reason. Now we have learned that unless the patient has a significant conjunctivitis, there is no risk for spreading the virus through the tears. I don't know the position from the panel, but as I told you, I read a lot of questions coming from our audience about this, and also about how do you make a tonometry in these times.
Yeah, I would agree with you, Roberto. In my opinion, I don't think the risk is high, even though 30% of patients have some virus genome in the tear film, maybe because of the nasolacrimal duct connection. And this is my opinion. If someone has something to say. Okay, Dr. Hassan, you have.
Yeah, I would like just to comment in your question, Dr. Murad. When you have a top emergency, macula on, retinal detachment, and positive COVID, obligatory you have to operate in that. You cannot say that I will not operate. And then you have to take your precautions for all of the staffs. In our hospital, we are doing a mask, letting the patient wear it, and we will be putting as well plaster over it at the upper part so that there is the retrograde breathing not good to work. And we are using the betadine for the disinfections and taking all the extensive PPE protection at this time. But this patient needs the surgery, so we cannot distancing, and usually we are not allowing for a lot of people in the operating rooms, and trying as much as possible to clean everything after these patients. There is another issues because of negative and positive pressure in the room and spreading of the disease, but not yet now. I think so, established.
As you know, the negative and positive, this is different. All the OR are positive pressure. So if you because it's a sterile place, and now if you make it the opposite, if you want to isolate a patient with a COVID-19,
we'll get the patient.
Exactly, you have to have a negative, so no infectious aerosol go outside the room, and the technician can shift it in a way. We have a strategy in King Abdulaziz Medical City that every patient go for a GA, he has to do the test, the PCR. This is number one. And the idea behind that, because the anesthetist is gonna intubate that patient. And you elaborate on a good point, which is that when you are using an air fluid exchange, you're gonna push something outside the patient eye. And the question in that field, do you really need to wear a surgical mask, or do you really need to wear an N95 mask? As you know, the 95 mask blocks blocks 95% of the organism that coming inside to you, while the surgical mask is for the sake of the patient. It's prevent the droplet from going outside. I would be happy if it's economically wise to use the N95 during any surgical retina rather than cataract or any other else. Samuel, you want to add last things?
No,
Can I add something to your point?
Yeah, the current practice that I am following is that I use a surgical mask over the N95 mask when I'm doing a surgery. So that's what I do, given the fact that I can easily ETO sterilize my N95 masks. So I reuse them at times, and which is important. Though the surgical masks would be disposable, but N95 you can ETO them, ethylene oxide sterilization, and you can still use them again.
Nice invention. If you have a good oximetry during the OR time with a double mask. Dr. Alex, you want to add something?
I apologize, I can't hear Saumil, so I'm confusing the situation. This point you was talking about before is important. What they're talking in Italy now, Mario Romano, he was talking to use negative pressure in the operating theaters. If you have negative pressure, this goes out. If you have positive pressure. With the virus goes around the environment. So yes, we need to maybe rethink some points of our surgery.
Okay, thank you very much, Alex. Saleh Al-Amro, Prof. Saleh Al-Amro is with us now from Saudi Arabia. Can you unmute yourself, or I will do it for you? Can you unmute yourself and
yes,
please, we hear you now.
Yeah, well, I think most of the points were tackled by the respected panel. But now regarding the injection, as all of them said for AMD, I will continue. But for the diabetics injections, we continue with all the precautions for these because we don't know for how long is this going to happen, and if you elect to wait 1-2 months, probably this is also a reasonable approach. But longer than this, I think there is no much of a benefit of delaying it so much. Plus the fact that if the proper precautions taken, I think now all the sort of the transmission, and especially that if the one coming to an office, a private center, or sort of a hospital, that it is not for the care of COVID-19 patients, I think these are a reasonable environment. And I will go the way that I mentioned earlier.
Thank you very much, Prof. Saleh. Dr. Muhammad Al-Malki, are you with us? Do you have last comment or question? Can you unmute yourself? Okay, unmuting is not really working with Muhammad Al-Malki. I think in this point, maybe...
Yeah, Abdullah.
Yes, Muhammad, can you go, please?
Yes, Abdullah. Actually, it was really a very nice talk and a very nice collection from all the countries. Actually, I have some comment and very small question. You know, for the diabetic macular edema,
We can't hear you.
Muhammad, I don't know why you have an issue with the connection with Muhammad. Okay.
Not anymore with us.
Okay, so I think maybe I will share with you this video that was made by the Communicable Disease. If you get one day a call for examining a patient with a COVID-19 in his room, isolation room, this is the share from King Abdulaziz Medical City, and it will be a pleasure to share it with you. Do you see the...
Yes.
Okay. So this is the item, you will need it. Still, you have to do sterilization. Double cover. Between wearing and touching the bags, sterilize. N95 for a confirmed infected COVID-19. Face shield or eye shield. Gloves should cover the gown. Take care of wearing, the same take care of removing. Unfortunately, this is cost a lot unless you sterilize. Important step of rolling. Sterilize again. Hand hygiene, always. Don't touch the mask. Sterilized, always. So this is the video, and this is for those who are not confirmed. Of course, better to proceed with the first one, but this is very costly. So this is only for those who has non-confirmed disease. Okay.
Can I say something about the injections?
Yes, please.
Okay, the only thing I would like to add is whenever we see a patient or when we call a patient for injection, and I'm talking about the diabetic edema, we have to consider all the people they will get in touch until they reach the hospital. So many people, at least in Greece, they have to take the bus, they have to take the underground, they have to ask for someone to take them or get into a taxi. So it's all that. So when we are at the peak level of the infection, we have to consider that as well. It's not just us getting in touch with the patient or the nursing staff.
Okay.
That's all I wanted to add.
And also, Maria, we need to consider maybe some to inject things like Ozurdex, for example. But from the other side, then you need to control the IOP of the patients.
Yes, in Israel, what they did is that they made units that they were visiting the patients at home to inject the elderly.
And in Israel, they also do home OCT.
Yeah.
Yeah, maybe in the future we will get confident with things like that, you know. And I don't know if there is a home-based intraocular pressure way to do, you know, to measure your pressure by yourself.
It's always there. The OCT, the home OCT, the invention is always there since a long time. The issue is the resolution. Are you going to have a good resolution or no? This is the issue for the time being. This is why it's not really applicable everywhere. Hopefully in the future we'll get Dr. Mohammed Al-Malki.
Abdullah,
Back
sorry, but it was disconnected. I don't know why. So my point here, actually, maybe 2 points. The first thing regarding the HEPA filter in OR, is it mandatory or not? Especially we are, you know, as you said, you know, there might be a resonation in the OR. The other thing in OR, maybe we, you know, be maybe not positive and negative pressure, but we might think of ISO because, you know, negative pressure might increase the risk of surgical wound infection because, you know, everything from the corridor will come inside the OR, and positive pressure will push everything from inside the OR outside. But we might think of ISO not to have anything from outside, and also not to push anything from inside the room outside. So, with the infection control, we might think of, this strategy. The second thing regarding the injection, whether to inject or not, I'm taking it from the patient perspective. And if I give the choice for the patient, and I told him, that there is an infection, there is a risk of infection you might get when you come to the hospital, he will think 100 times before he come. I personally, if I have an appointment, then I'll think 100 times before I go to an appointment.
This is at the beginning.
Emergency. If it's emergency, then yes, I agree, and nobody will say no. I will not do the emergency. I will not do the injection. But for something like diabetic macular edema, which is there for months, then I think delay it for a few months till the view become more clearer. Maybe it's a wise decision.
Okay, thank you, Mohammed, for this participation. Even though patient hesitation is just the early phase, later on we will have another crowding coming to the hospital because they will get worried of delaying the injection. I do want to take longer time. Last comment from Dr. Pietro Monaco.
Yes. Can you hear me?
Yes, we can hear you.
Yeah. Hello. Congratulations for this very interesting webinar. Yeah, I have a quick comment about the Alex talk. Yeah, I think in the future, I think probably we will not see a lot of ischemic retinal problems because they can be associated to CID picture in COVID-19 patients. That can happen at the end of the disease, and unfortunately, we know that those patients have a very bad prognosis.
Well, maybe we will find them in the anatomical, but it's quite difficult to do that. In the anatomy, we will have to ask the anatomopathologist to check also the eye.
Yes, yeah, probably we have to fix ourselves much more about the drug problems on the retina, probably. For
Pietro,
as you said,
another thing is we need to think if in the kids we have this kind of microvascular peripheral problems. Maybe the patients that will arrive the next month in our clinics with this type of problems in the eye, we need to check them also for COVID, and to see if they are correlated with positive COVID history or COVID positive in the moment where we visited.
Yeah,
and to be aware of that.
Okay.
Yeah, Alex, but I told you, I think this situation, we can find this situation at the end of the disease. So in the previous part with the patient is asymptomatic, we can find these findings.
Okay, thank you very much, Dr. Pietro. I would like to thank all of our panelists for their participation, for their preparation, taking time. We stay like 2.5 hours almost, and with a very nice discussion. If we continue, we will never stop. I really myself enjoy talking with you guys, and I would like to thank all the audience for their participation, staying with us till the end, voting for our poll, and also definitely we like to thank all of our association and sponsor. Thank you a lot, all of you, and see you hopefully soon, every other Friday at 7 p.m. for another talk. Thank you.
Thank you. Bye.
Thank you. Bye. See you soon.
Bye-bye.